Hello.
Hello.
Gaurav bhai?
हाँ सर.
Madam, please begin.
हाँ.
Madam, please begin. You are live.
Yeah. Good afternoon, everyone. Today we have session by Dr. Paras Joshi. I'll introduce him as a clinical therapist. He has worked and has 11 years of clinical experience. And Sir has also worked as the assistant physiotherapist in the Parul University of Physiotherapy during 2009 to 10 and at the Rajkot KK State Physiotherapy College during 2010 to 11. Sir has also written the book of the dry needling and uh, also awarded for the significant contribution award in 2013. Sir is also author of the dry needling, which is the book published for the physiotherapist. We'd like to begin the session with Dr. Paras Joshi here. Sir, we welcome you on behalf of the Parul University.
I guess I may start now. Yes, ma'am.
Yes, sir. We'll start with the session over here.
Okay. Good afternoon, everyone, and I would like to sincerely thanks to the management of Para University, Principal Sir, Ahmedabad Physiotherapy College, Principal Sir, Baroda Physiotherapy College, and Dr. Dhaval Patel for giving me this opportunity to present this dry needling in front of the students of Para University. It's my home college. I did my first job in 2009 in Para University. So it is entirely my pleasure to be with them again. Without wasting the time, I would like to start the presentation. Uh,
Yes, sir.
I hope the screen is visible to you. The trigger point is just, dry needling is just a tool. For that, we need some base to clear this tool. So what I have decided is to describe this trigger point or trigger points and then how the dry needle is useful in treating those trigger points. These are the abbreviations what we are going to use, and as the session progresses, I will elaborate on that. Now, this is the outline of this webinar. First, we'll discuss about the drawbacks of the physiotherapy practice and advantage of dry needling over these drawbacks, and then what is the advantage of physiotherapy practice over the dry needling. Then we'll see the difference with the acupuncture, what is the scope of dry needling in physiotherapy, how you assess the trigger points, and what is pain physiology, what is the physiological and therapeutic effects of dry needling, what are the indications, contraindications, adverse effects, complications of the dry needling. Then we'll take a look on the hygiene measures, what we should use during the practice, what are the insertional technique available for this dry needling. There are two types, superficial and deep dry needling. We will take an outline on that, few evidences, and if this pandemic is over on time, then I would like to take the practicals also for you guys. Now, what is the drawback of physiotherapy practice? As whatsoever a practice era for me, what I discovered is physiotherapy is time consuming. If you ask the patient to come for a couple of days, they may be ready to come. But if you ask them to come for 15 days, 10 days, so it will be a little longer for the patients. The second disadvantage is the time. That means if we are treating the patients for 30 minutes, 45 minutes, so daily taking out that time from their routine is not feasible, particularly in the country like India. Now, the dry needling is a major advantage over the physiotherapy practice in these limitations. How? When you use a dry needle, it will give an instant pain relief, provided your assessment should be correct and your technique of insertion should be correct. So it will give 100% result on the first day itself. Significant pain reductions can be felt by the patient up to 50%. So in one session only, and some may feel 80-90% relief in just one session. So this is the advantage of dry needle. But what is the disadvantage of dry needle? Dry needle is just a symptomatic treatment. For example, if patient is having trigger point and you are treating the patient is getting relief from the trigger point, but if the root cause is still there, say for example postural abnormalities, any repetitive work, any weight carrying practice, or any hormonal deficiency, so this trigger points again it will develop. So physiotherapy is the science which treating the trigger points or any other pathophysiology from the base. So this is the major advantage of physiotherapy over the dry needle. So dry needle you can use as a tool to just get rid of the pain, but it is not going to take the patient completely out from the pathology. Now, how fast it works, I have some examples here. There was one orthopedic surgeon. When he came to us, his NPRS, that is numeric pain rating scale, was 8, and after just one session, he was relieved of the pain to 1, and the palpable taut band was also relieved up to 30% in that surgeon. This is the another case. There you can see the NPRS went to 0 from the 4 in just one session. This is another case where we see that dry needling for biceps muscle, there is a significant pain relief in the patient. Another one patient, here we can see NPRS is going down along with the movements are increasing. There is a significant improvement in the range of motion also. So we can say that dry needling works phenomenally good on the pain, but at the same time it works very good on the movement restrictions also. So here are the two outcome measures what we have seen so far. One is pain. So when the patient comes to you, and if you are going to treat the patient with the dry needle, the first outcome measure you are taking is NPRS, and the second is range of motion. Whenever we see the patient with the trapezitis or trigger point in the trapezius, the neck movements are distorted, the range of motions are not good. So you take this range of motion pre-session, and after giving the session, you can take the another. You can take once again the range of motion, and you can see the significant difference in range of motion too. So dry needling is a tool which can give you a rid of pain, but at the same time it improves the range of motion also. Now this is another case where also you can see that there is a significant pain relief is there, just 1 or 2 session of dry needling. This is my migraine patient, and where I am getting a very good result with the help of needles. There was a case of idiopathic thumb pain, and she was suffering from this idiopathic thumb pain. There was absolutely no cause available in assessment. She has done almost all the reports of rheumatoid arthritis and all, but still she was suffering from this pain since almost 2 months, sorry. And then when we treated the patient with the dry needle, she is absolutely fine now. So what I would like to say is dry needling is working very good if you want to get immediate pain relief. Now, what is the goal of this webinar? The goal of this webinar is to understand the trigger points first, then what are the effects of needles in terms of physiological effects and therapeutic effects, and what are the indications, contraindications, and dangers of needles, and how you have to manage these complications, how you can manage these complications. Now we'll start with the needling. What is the definition of dry needling? See, according to American Physical Therapy Association, the dry needling, it is a skilled intervention performed by a physiotherapist. A skilled intervention means both in terms of assessment and in terms of intervention. If we are sound with the assessment and if we are sound with the treatment technique, then definitely we are going to get very good result with the help of dry needling. That means your assessment should be correct, pinpointed assessment, and your treatment technique should be correct. Then you are going to get very good result. And believe me, it is very skillful, because you are inserting the needle inside the muscle, and you have to avoid the large arteries, large veins, and large nerves. You have to look after certain contraindications like hemorrhagic disease. So it is a very skillful technique, and you have to perform with you need to have a very much of a practice before practicing it on the patients, because sometimes we miss the contraindication. Sometimes we prick the large vessels and it will end up in a mess. So it is a skillful technique and you need to learn from a practitioner before practicing it. Now what we use is a filiform needle. So filiform needle is a needle which is a thin needle which we use. You can see in this figure here. We penetrate the skin and underlying muscles. We reach to the muscles where the trigger point lies. Gujarati ma kahiye to raina dana jevu hoy. There you have to reach and you have to penetrate those trigger points, and you have to stimulate that trigger points. When you stimulate this trigger points, you can achieve the outcome in two ways. One is improving the range of motion, and the another one is reduction in pain. Yes, it may be painful if the trigger point is active and you are working preliminarily on the trigger point. During the treatment session, patient may experience pain, but after the session, there is a significant relief from the pain. Now, what are the structures that you can treat with the help of these needles? You can treat muscles, you can treat ligaments, tendons, you can treat the fascia, you can treat the subcutaneous scar tissues, you can treat the peripheral nerves, you can treat the neurovascular bundles, and any musculoskeletal pain syndrome can be treated with the help of dry needle, but the theory is different. What today we are going to talk is about trigger point and the use of needle. Now the question arises, is dry needling is within the scope of this physiotherapy practice? So as far as your syllabus is containing dry needling, you are allowed in India, provided our college should be UGC recognized, and in syllabus it should be mentioned that as dry needling, that should be mentioned, then you can practice. Now there are some supportive statements from the American Association of Orthopedic Manual Physiotherapists. What they stated is, yes, you can practice the dry needling. They have certain evidences on what they are taking to the journals and allowing us to practice the needles. These are few references. This is the APTA resource paper in January 2012, and they have covered almost all the things about the dry needling, and you can read that. It is online available. This is North America, and you can see the states marked in green where this practice is allowed. Now there is a discrepancy between acupuncturist, and there is a dispute between acupuncturist and physiotherapist that this tool is same and this is called as acupuncture, this is not called as dry needling, and it is there in Western countries too. But there is a difference between the acupuncture and dry needling. I have done my MD and acupuncture, so I can say that there is a difference between the acupuncture and dry needling. Now what is the difference? We'll quickly see. See, acupuncture looks like this. That is, you hit the arrow somewhere and patient's getting cured somewhere. For example, in this elephant is getting arrow in the legs, but he is getting cured his neck pain. So acupuncture works like that. Acupuncture, apart from pain, acupuncture is working on hypoglycemia, addiction removal, painless delivery, migraine, any hormonal imbalances, and many more things. But as far as dry needling is concerned, it mainly works on the pain. Now, acupuncturist uses different type of needles. See, the different types of needles you can see over here. Okay, we are not going into that. Apart in this needles, there is one needle that is called as filiform needle, and that we use here. That is the filiform needle that we use in dry needling. So this is the one similarity between the acupuncture and dry needling. There are many theories and evaluation available in acupuncture. You can see here. These are the theories of acupuncture. They take a history of dream. They examine your ear, eye, nose, smell, tongue, etc. Whereas what we do is we do general physical therapy assessment. What we do as a physiotherapist, that we do here to treat the trigger points. So there is a difference in evaluation. There is a difference in theory too. Like they have some traditional theories. We are not going in that. I will give you in detail. I will give you some notes. You can refer that for that theories. But physiotherapy, as far as physiotherapist is practicing dry needling, they have their theory like pain gate theory, endorphin enkephalin theory. So on that theory, we are working on patients. Now, there are a classification of acupuncture points. One of the points are SC points, that is floating tenderness points, and these are our trigger points. So there is a similarity of a points. So what we are doing is we are physically doing the physical examination. Here we are finding out the trigger points, and then we are treating those trigger points. This is a type of acupuncture, whereas in dry needling there are no such types. Now there is called as a DECU sensation. That means this is a 4 to 5 types of sensation which patient feels. That is pain, heaviness, distension, soreness, and numbness. So this kind of sensation are bound to happen if you have hit the right thing. For example, if you are inserting the needle into the trigger point, so patient may complain of this heaviness, distension, soreness, etc. while needling, after the needling, and this is quite common. No need to worry about it. Now, what is the history of dry needling? How exactly it evolved? In 1940s, Dr. Janet Travell, she was identifying these muscular trigger points, and she was doing the wet needling. Means she was injecting the drug on those trigger points, and she was getting the result in terms of pain is radiating. For example, if there is a trigger point over here in trapezius, if you inject the needle over here, then there is a radiating pain which shoots up to the posterior aspect of the neck, and she was getting the same result with the help of dry needle also. That means without drug also, if she insert the needle, she was getting this radiating pain, and after the treatment, the patient is getting relief from the pain. So that was the first generation of modern dry needling in 1940s. Then they come to our second generation of dry needling in 1970s. That is by Dr. C. Dung. And what C. Gunn has found is intramuscular stimulation. That was based on the concept of intramuscular stimulation, where basically the pathology is in the muscle, for example, a trigger point, but the root is in the nerve. For example, if the patient is having cervical radiculopathy, and because of that there is a trigger point development in any of the muscles supplied by the same nerve, that can be called as a second generation. This can be called as this model, that is secondary development of the trigger points due to the irritation of the nerve roots. And the concept here is intramuscular stimulation, where you just not need to insert the needle, but you have to manipulate also. You can do the manipulation with the help of hands. There are needles available with the springs on the head. So even if a minor breeze is coming or air is coming, the needle is sway here and there, it will give stimulation. And one more thing is you can give a stimulation with the help of electrical instrument also. In 1970s, Dr. H.C. Dung, he discovered the homeostatic points. That means one point can be used, only one point can be used, which can treat the patient in either way. For example, patient is having diarrhea, you can treat the patient. If patient is having constipation, you can treat the patient with the same point. If patient is having high blood pressure or low blood pressure, the point is same. That is called as a homeostatic point. So that was the third generation of modern dry needling. Now we'll learn about normal muscle contraction. Now, what is normal muscle contraction? We all know that we need to have a calcium influx and ATP to go for the normal for the healthy muscle contraction. So when there is a calcium influx, the calcium comes in, and actin, myosin which slides along with the actin. Actin's head is pulling the myosin, and there is a muscle contraction, right? So now we'll see what happens in trigger point. See, first we see the definition of trigger points. Trigger points are discrete, focal, and hyper irritable spot. Discrete means it is, you can easily isolate those trigger points. It is local, you can spot the trigger points very easily, and the points are very hyper irritable. Means if you press those points, patient may have jump sign. Patient will literally jump that, oh, he has a pain over there. And it is located in a taut band of skeletal muscle fiber. So if you carefully palpate the muscle, If you carefully palpate the muscle, you will see a taut band, and inside that you will feel there is something sliding under your finger. That is trigger point. These trigger points are painful on compression, and that can have a referred pain and referred tenderness. Now, for example, as I have mentioned, trigger point 1 is here in the trapezius. If you compress it, at the time of compression, there will be a radiation of the pain that is there in the trigger point. Now, trigger points are very well classified, and you can refer the book David J. Simon. It is very well classified trigger points. That means it is fixed. For example, trapezius, there are 7 trigger points in trapezius. It is fixed. Their location are fixed, and their reference zones are fixed. Where the pain is radiating is fixed. Everything is fixed. So trigger points are a focal points, already classified, already mentioned. We cannot invent a new trigger point, in short. Right? Then there is a motor dysfunction. If patient is having a trigger point, patient may have motor dysfunction in 2 ways. One is reduced range of motion, and the second is in terms of strength. Means patient is having a weak muscle, and that is not due to the absolute weakness, but that is because of pain of the trigger point. Patient show the sign of weakness. Now, trigger points is oftenly misdiagnosed. You can see I have some statistics that in epidemiological studies from US shown that up to 85% of the patients are misdiagnosed. They are actually the patients of trigger points, but they are misdiagnosed. And you can see the another statistics here that almost even from the dental clinic, 55% of the patients are having the trigger points of temporalis or masseter muscle, but they have been misdiagnosed as some tooth pain. So trigger points is a very common entity, very common disorder. You can say a syndrome. It's a part of syndrome. Trigger point is also a symptom. It is not a disease. So you have to find out the underlying disease. For example, cervical radiculopathy or any upper cross syndrome, Libland discrepancy, etc. And because of that, these trigger points are developing, and it is misdiagnosed often. Now, what is the pathophysiology of this trigger point? It often forms at the muscle end plate, where near the neuromuscular junction. The continuous irritation of this end plate will do the excessive release of acetylcholine, and because of this, the muscle remains in constant contracted stage, and this is called as a locking of a muscle fiber. And because of this, the trigger point gradually develops. Now, what are the causes of this trigger point? One is biochemical changes, that is changes in the pH of a muscle. Then any chronic overuse, for example, computer operator or gardener, they may develop the trigger points in extensor muscles of the wrist or trapezius. Then any muscle injuries. When the patient is having any muscle injuries, you may noted that a patient with a calcaneal fracture or any other muscle injuries, you can see that patient is complaining of the pain all over the leg. Sometimes it is tender. So because of these muscle injuries, there is a development of trigger point. Central sensitization, we'll discuss this term later on the presentation. Then there is a prolonged poor posture. Because of that, the trigger point may develop. Again, we can see an example of a computer operator is always sitting with the head poked out. This will give a prolonged load to your trapezius and deep occipital muscles, and you may have the trigger points on trapezius and occipital muscles. Lack of exercise and lack of sleep may get trigger points. Then there is a hormonal imbalances like thyroid, estrogen, blood sugar. So if patient is having any of them, they may repetitively developing the trigger points. Then there is a nutritional deficiency like vitamin B12, iron, vitamin D, zinc, manganese, and the congenital factors like limb-band discrepancy, hemipelvis, short arm. So these are the things which need to be evaluated carefully when you are treating the patient with the trigger points. You have to see for the any biochemical changes. You have to look for any chronic overuse, patient's occupation, then patient's history of trauma. Earlier he had any history of trauma or something like that. Whether patient is in stress, he has adequate sleep. What is his nutritional status in terms of the given things? what is his hormonal status if a patient is particularly a female. Then these are the things you need to evaluate, and if we are working on these things, then definitely we'll get the good result. But if only we give the dry needle, and if we are missing out any of these points, we will not get the result. Now, this is the different types of overload which may produce the trigger points. One is exertional overload, means lifting the weight at once. Then overuse or repetitive stress overload. For example, if gardener, any biomechanical overload, like there is a disturbance between the agonist, antagonist, and synergist. A postural overload, the posture is not proper. Antalgic postural overload, when patient is having fracture, is bearing the more weight on the unaffected side, so it may give you such kind of problem, trigger points. Then referred pain overload and muscle trauma overload. So these are the different types of overload which you need to evaluate. Now, this is something interesting, dysfunctional progressional sequence, how these trigger points develop. For example, if patient is having increasing muscular tone, for example, patient is repetitively plucking the flower, he has the occupation of plucking the flower, so extensor muscles are repetitively working. So what happens is there is a constant increase in the muscular tone of the extensor muscles of the group. So these muscles are remaining in extension, and because of this, the muscle remain in contracted position. There will be a metabolic waste products and ischemia, because of this contraction, there will be a strangulation of the micro vessels. So when there is a strangulation, there will be an increase in metabolic waste product, there will be ischemia and edema. It will give rise to the pain and hypertonicity. Because of pain, the patient is not moving the hand properly. It will again give the hypertonicity, and it will sensitize your CNS. That means now your central nervous system is not working properly to eliminate the pain. Natural pain mechanism is hampered. Because of this hypertonicity, for example, because of this hypertonicity, the flexor muscles, extensor muscles are tight and flexor muscles are weak. So flexor muscles will be phasic and weak, whereas the postural muscle or the extensor muscles will be tight. So what happens? There will be an involvement of the tendinous structure. For example, in case of tennis elbow, if the patient is keeping the hand in always in extension, so there will be an involvement of the tendinous structure over the flexor compartment of the elbow. That is at the site of golfer's elbow, flexor muscles, which originates from the medial epicondyle of the elbow humerus. So there will be a spore formation, and there will be a periosteal elevation. Because of this, the joint movements are painful, and there will be a wastage of energy, and patient may experience fatigue. So you may notice that patient with the chronic pain will often complain you about fatigue also. Okay, thaki javai chhe. So that is because of this dysfunctional changes. You can see the spore formation here in case of tennis elbow. That is the calcification of extensor tendon. Now, what are the types of trigger point? Broadly, it is divided into active trigger points and latent trigger points. What is active trigger point? Active trigger point means, in simple word, patient will pinpoint, tell you that, sir, I have a pain over here, I have a pain over here, fixed. And that points are tender on palpation, and that have a characteristics of referred pain. And this referred pain is also fixed. For example, પેશન્ટ આપણને આવીને એવું કહે કે સર મને અહીંયા પેઇન છે અને માથાની પાછળની બાજુમાં બી દુખે છે, તો એઝ અ ટ્રિગર પોઈન્ટ પ્રેક્ટિશનર, સોરી, એઝ અ ડ્રાય નીડલિંગ પ્રેક્ટિશનર, મને મગજમાં આવી જશે કે that is trigger point 1 of a trapezius, because I know the referral pattern of that particular point. So there are fixed referral pattern of each and every point in the body, and because of this fixed pattern, it is easier for us to identify which trigger point patient is complaining about. This is dull ache pain, deep pressing pain, sometimes burning sensation is there, and along with the fatigue. You can notice that patient may have sweating, goosebumps, and tearing of the eyes when you press these active trigger points. Now, when these active trigger points are not treated properly, they turn into latent. That means it is usually silent. Now you see that patient is trying to find out where this point is. Patient is trying to find out the point. Is here it is, you need to find out the point. It is not pinpointed. There is a referred pain, but only on the compression. When you compress significantly, there is a referred pain, and there is a distorted muscle movement. For example, if you ask the patient to rotate his head, so how we rotate is smooth, but when the patient rotates with the active latent trigger point, the trapezius, the movement will be distorted and it is not smooth. The another examination of this is there is a stiffness and weakness of the affected muscle. Muscle is stiff when you palpate and it is weak when you take the MMT. Now another is satellite trigger point. That is when one trigger point gives rise to another trigger point. That is called as satellite trigger point. For example, I have a trigger point on supraspinatus that is supplied by C5, and continuous irritation of this supraspinatus trigger point can give rise to the secondary trigger point in deltoid middle fibers that is also supplied by C5. So when you irritate mechanically to a one trigger point, there will be a development of a secondary trigger point in the same myotomal area that will be called as a satellite trigger point. There are two more trigger points, central trigger point, which is at the center of the muscle fiber, and attachment trigger point. It will be attached to a musculotendinous junction or a tendo-osseous junction. For example, a tennis elbow. Now this is the difference between trigger and tender point. In trigger point, there is a jump sign and twitch response that we will understand later. In tender point, there is a local tenderness. Okay. In trigger point, there is a referred pain presentation, and in tender points there is no referred pain. Now, how you should assess the patient? Palpation is the key. When you assess the patient, when you palpate the patient, you should be palpating the patient's muscle perpendicular to the muscle fiber direction. And this muscle fiber direction, when you palpate, then the consistency of the muscle is harder than the normal one. Then you can see the patient's expression when you are palpating this muscle fiber. Patient may experience a pain, and when you come on affected muscle fiber on trigger point, there will be a local twitch response. Local twitch response is involuntary muscle contraction of the affected muscle fiber when this point is irritated with the help of manual pressure or needle. So sometimes you can see that twitch response, or sometimes you may feel also, if your hands are placed accordingly, you may feel the twitch response, you may see the twitch response. So these are the things which confirm that there is a trigger point. When there is a twitch response, you can ask the patient whether the pain is radiating to any particular area, and patient will tell you, yes sir, it is going up, it is going down in the arms, etc., and you may confirm that there is a trigger point. Now these are the confirmation criteria of a trigger point. One is pain, referred pain, and local twitch response, and there is a spontaneous EMG activities. With the help of EMG also you can find out these trigger points. Spontaneous electrical activity means usually when you insert the needle, the insertional activities last for only 2 to 5 milliseconds, but when you insert this needle in the trigger point, it will last longer than that. That is a confirmation criteria to have a trigger point. Now the skin over the trigger point is difficult to glide. You cannot glide it. It will have a sensation of drag. I will try to come there and explain you practically when this situation is under control. So there is a sensation of drag. Skin elasticity is less, and skin is more adherent to the underlying structures than the normal one. Okay. Now there is a role of complete general physical examination. Means this is just a local examination what I have mentioned, but you should completely you should do the general physical examination before going or jump into this local assessment. Like the way we take history, gender, we take the nutritional, sleep, nutritional value, hormonal values, any congenital deformity. So there are a wide variety of assessment what we should do before jumping into the local assessment. Okay. Now active trigger points are more irritable than the latent one, and they show the greater response on the examination. And when you inactivate those trigger points, suspected trigger points, patient has to be relieved from the pain. For example, if you find out a trigger point and treating that trigger point, patient has to get relief from treating that trigger point. If you are not able to do that, that means your assessment is wrong. So if patient is having active trigger point and you are treating it, patient ne rahat madvi જોઈએ. If you are not able to relieving it, that means you are doing something wrong. examination of mechanical precipitating factors are must. For example, કેટલા mechanical precipitating factors હોઈ શકે છે that is out of our imagination. Sometimes a new shoe can give us to a trigger point, new shoe wear. Sometimes when you carry heavy weight on a one side, that can give you a trigger point. Sometimes a new garment, new clothes what you are wearing, that can give you a trigger point. So these are the mechanical precipitating factors. The new mode of traveling, for example, in auto rickshaw you are sitting one side, that can give a trigger point in your gluteus maximus or any quadratus lumborum. So there are many mechanical precipitating factors that we need to evaluate for assessing these trigger points. This is the assessment criteria we are taking. You may have a look at it later. This is the recommended criteria for identifying the latent or active trigger point, essential and confirmatory observations both. Now, what are the common treatment of this trigger points, what we may use along with the dry needling? That is myofascial release, strengthening, mobilization, etc. Now, one important thing is you cannot strengthen a muscle that has a trigger point. Now, what we do generally is, like for example, if patient is having a trigger point in biceps, and if we take the MMT will be around 3. So what we do as a physiotherapist, we immediately put a dumbbell on his hand and we'll ask with the TheraBand or dumbbell, you just start exercising, we need to strengthen your muscle. But that weakness is not absolute. That weakness is not true. It is a false weakness. So what you need to do is you need to first unlock that muscle. You have to first treat that trigger point, and elongate that muscle. You have to get the proper length of that muscle, and then you may start strengthening when you get this proper length. So there is a length tension relationship between the muscle, and you need to respect of it. If you treat a patient with a trigger point with the resistive exercises, we may worsen the condition. Now, these are the one case of Bharti Ben I would like to discuss. She was having tennis elbow since 2 years, and she was in Mumbai. Then she came to Rajkot, and she was referred to me by one of my students. And what I found out in her is she was treated with the injectable steroid twice, but she was not getting adequate relief. So what I found in that, there was a trigger point in her extensor compartment of muscles, extensor carpi radialis, longus and brevis. She was having trigger points, and what we have done is that we have found that she was having history of trauma in the proximal humerus. She was having a fracture of proximal humerus. So because of that, she was having weak fixator muscles of rhomboids or middle trapezius. She was having very weak trapezius, very weak rhomboids. Because of that, the whole load is coming here to the extensor compartment of the elbow. And though that was the reason she was not getting proper relief. And we gradually started treating that patient. And you can see the exact sequence here. I have first relieved the trigger point, then I have elongated the muscle, and then we started the strengthening exercises. So this is the exact sequence we should follow. Now, after the trigger point, what patient may tell you after the treatment, what the patients may tell you. One is patient may tell you that immediately after one session I am getting good relief, fine. The second thing is soreness. Patient may complain up for soreness up to 48 hours. Fatigue, that is if patient is having chronic pain, patient may fatigue experience. Workload of the muscles may change. Okay, so there will be a change in the pain pattern. For example, the muscle which was not working since so long, we are releasing that muscle, and that muscle is taking part. So there will be a disturbance in the synchronization of the muscle fibers working together. So the pain pattern છે એમાં 72 કલાક સુધી 72 hours સુધી થોડો change થશે, that is normal. And sometimes untreated syndromes or symptoms feels better. For example, trapezius માં pain છે, rhomboids માં भी pain છે, trapezius માં treatment આપી, rhomboids માં भी સારું લાગે છે. So that is normal. This is the appropriate trigger point treatment. Okay, you may read it later. These are the techniques which I use along with the dry needle. That is ischemic compression, then positional release, that is then MET, then we use Rudy's reciprocal antagonist facilitation approach, and these are the things we usually do along with the dry needle. Now let us analyze your diagnostic skill. For example, if patient complains you of having a pain while coughing, sneezing, sitting, lying down, and turning on the bed, the pain is in the anterior medial aspect and lower lateral aspect of the buttock. Walking up and getting up from the chair and turning in the bed is difficult. So these are the chief complaint of patient. What we should think? We will always think that patient may have sciatica, pocket sciatica, or SI joint pain, something like that. But the actual cause may be like this. Quadratus lumborum trigger point પણ હોઈ શકે છે, and we may miss these trigger points. We need to be very careful in evaluation. This is the physical examination of quadratus lumborum. I would like you people to read because there is much things we have to discuss. So this is the examination of quadratus lumborum muscle and how we are going to treat those muscle imbalance. See, these are the trigger points what we usually see. You can see this is the trigger point of extensor carpi ulnaris. This is the temporalis trigger point. This is the ECRB and ECRL trigger points. This is abductor hallucis longus trigger point. This is again extensor tendon of the medial fiber, and you can see the referral pattern is showing in the red, whereas the trigger point is here, and referral pain is here. Okay. Now, what is pain physiology? We know that when there is a pain transmission, the unmyelinated C fibers come into the play. They send the signals to the dorsal horn of the spinal cord. So when this dorsal horn of the spinal cord is firing these pain signals, we perceive the pain. When we perceive the pain, there is a pain relieving circuits which get activated, and we may feel relief from the pain. This is the natural pain mechanism. We all know that what is C fiber, A delta, A beta. I'm not going into that. Now, how this pain modulation naturally works? There is a peripheral modulation and central modulation. In peripheral modulation, when there is activation of C unmyelinated fiber, there are many algogenic agents which come into play. That is substance P, that is bradykinin, histamine, CGRP, NGF, TNF, interleukin 1, etc., etc. These all release, and this will transmit the pain faster to the brain, so that pain relieving circuits get active. And another thing is it causes vasodilation and inflammation, so that there will be adequate blood supply where it is needed. So this is the primary two functions detail. I will be sending you one presentation and one book, soft copy, that you can read. So this is the substance P. This is bradykinin, histamine, calcitonin gene daughter peptide, prostaglandin. So these are the hormones which release at once when we have a natural pain perception. Then the another thing is central pain modulation. We know that how this central pain modulation works, that is pain gate theory. Then another one is endogenous opioid system. When there is a pain, there will be a secretion of endorphin and enkephalin, and this substance coming out of the blood-brain barrier, okay, and this will bind at the presynaptic level, that will release the dopamine, and dopamine will give you a pain relief. So this is the endogenous opioid system. Besides that, there is a serotonin. Serotonin is a vasoconstrictor in nature and helps to bind the blood clotting, and it will help in wound healing. There is the flight and flight response for the norepinephrine and noradrenaline, and dopamine is giving you a pain relief. Now there is central sensitization. When the pain lasts longer, okay, because of the continuous irritation. For example, if patient is having upper cross syndrome and patient is continuously poking his head, so there will be a continuous irritation of the trapezius trigger point. So the body will assume that this is normal, and the pain relieving circuits are not work properly. That is called as a central sensitization. In chronic pain patient, there is a hampered continuous conditioning pain modulation is hampered. That conditioned pain modulation means when outside the receptive field, when you give another pain stimulus, the first will suppress down. That is not there in the chronic pain patient. You can see in chronic pain patient, the dorsal horn of the dorsal horn ganglion is irritated, and it will send continuous firing of the pain transmission towards the higher centers. So this happens in chronic pain. Now, what is the physiological effects of dry needling? First is local twitch response. Local twitch response, as we have discussed earlier, it is the involuntary muscle contraction of the affected muscle fiber when this trigger point is irritated through a manual response or through a dry needle. There will be a local twitch response, and the muscle which is earlier in a contraction position, it is getting relaxed at once because of this local twitch response. So when there is a LTR, when you feel that during the dry needling there is a LTR, light twitch response, definitely patient will feel a pain relief. Now we understand this dry needling in four aspects. One is total taut bend, then local ischemia, hypoxia, and the sensitization. What is a taut bend? We know that the muscle is locked. Now when you give a dry needling, there will be a reduction in spontaneous electrical activity. What is spontaneous electrical activity? At the neuromuscular junction, because of this spontaneous electrical muscle activity, the muscle remains constantly in contracted stage. But when you give a needle at the end plate, it will discharge the end plate immediately. It will reduce the available SCH stores, and which will give rise to a lesser spontaneous electrical activity, and muscle is relaxed. If your needle is going around the end plate, motor end plate areas on the muscle fiber, that will discharge the muscle fiber itself, and there will be a light twitch response, and there will be a less spontaneous electrical activity. So the muscle which was tight earlier, it is now relaxed because of this dry needle. So this is the first thing of physiological effect of dry needle. The second thing is it causes the alteration in the length and tension of the muscle fiber. So when there is an alteration, there is a mechanical stimulation, mechanoreceptor, that is nothing but the stimulation of your A delta fibers, and your pain gate theory starts working, and patient may get pain relief. The another theory is blood flow. When there is a tight muscle, the microvessels are getting strangulated. So there will be a less blood flow, less oxygen available to the affected muscle fiber. But when you do the needling, there will be increase in blood flow and there will be increase in oxygenation. How? One is it activates the substance like CGRP and SP. That is when we do the needle, we are injuring the muscle fiber, so that there will be a release of this natural pain mechanism, and these algogenic agents like calcitonin gene-related peptide and substance P will release. This is because of the stimulation of C fiber, what we do via needle, and this will go for a vasodilation of the small blood vessels. Okay, and there is a vasodilation towards the site of needling and even to the remote areas also. Now, along with this needling, there is a hypoxic responsive proteins available, which are we can study show that these proteins are increasing with the help of needle. What is the function of this protein? This will cause vasodilation and this will cause angiogenesis. That means the formation of new vessels will be high. Okay, and there will be altered glucose metabolism. That means patient's muscle fiber is learned to survive in available metabolic activities. So because of this dry needle, the blood flow is going to increase. This has a good effect on peripheral and central sensitization. We have seen that if patient is having pain, there is a large concentration of substance P and CGRP. These both are active, and this will send the pain signals to the higher centers, and we perceive the pain. But when you give the dry needle, there is a significant lowering down after the light switch response of this SP and CGRP. So there is no algogenic agents available, no pain firing, and definitely the patient is getting the pain relief because of that. That is the effect of one single session of the dry needle. But when you give 5 consecutive sessions of the dry needling, there will be increased level of SP, that is substance P, but at the same time you may have this hypoxic responsive proteins available, and we know that the function of these proteins are angiogenesis and vasodilation. So there will be a more oxygen available for that muscle fiber which is earlier contracted and hypoxic, and there will be a pain relief. There is a positive effect on endorphin and enkephalin also. And this central sensitization, there is a hyperstimulation analgesia, that is Melzek and Wall theory. On that, the dry needling is working and centrally patient is getting the pain relief. Gate control theory, we know that when we stimulate the delta fiber, it will block the pain perception at the spinal cord level. Now, This is the effect on central sensitization. When you stimulate one trigger point, it will be relief on the secondary trigger point also, and that is because of the intact muscle fiber arc. Okay, there are studies available using the functional MRI. When you do the dry needle, the periaqueductal gray matter, which is the central part of the opioid circuitry system, it is active. So the natural pain mechanism, pain relieving circuits are active. This is the effect of central sensitization. It has a good effect on noradrenaline also. The remote effect is present, especially proximal to distal, distal to proximal, but the contralateral there is a discrepancy. But I have seen it. You treat the trigger point here and patient is getting relief over here if it is done correctly. There is a placebo effect, of course. Okay, there is an effect on the scar and adhesion. Now, how this exactly works, we see when you give a needle, it will, okay, when you give the needle, it will create a local microtrauma that will release the alcoholic agent, substance P and CGRP. These are vasodilatory in nature, so increase in blood flow. When you create a microtrauma, there will be activation of C fibers that will again release the SP and CGRP, and there will be increased blood flow. When these C fibers are stimulated, okay, that will go up and give pain to the supraspinal sites, and natural pain relief mechanism is activated from here because of the needle. Now, when you needle, there is a mechanical stimulation. We stimulate the A delta fibers and A beta fibers. There is a segmental block at the level of spinal cord, and there will be a pain relief. When you do a mechanical stimulation with the needle, there is a light twitch response, and it will reduce the spontaneous electrical activity, and patient is having the pain. So this is the concurrent many mechanisms occurring together to get the patient relief from the pain. These are the indications of the ACTA of dry needling: radiculopathies, joint dysfunction, disc pathologies, tendinitis. Where there are trigger points, you can apply dry needle. This is the anatomy of needle. You can see this is the root. This is the most delicate part of the needle. This is the most delicate part of the needle. It's shown the red arrow. This is handle. There is a tail, and with the help of handle, you insert the needle. That it should be learned practically. These are the sizes of needle. What we use is in the needle is 0.25 mm of the size and 25 mm of the length. That is 1 inch needle, 2 inch needle, 5 inch needle length are available as per the muscles we have to select. Now, this is the absolute and relative contraindications. We'll explain one by one. One is when the patient is not having the consent. Okay, you should not perform dry needling. There is a specific drug, especially patient is on like blood thickening drugs, like patient is having hemophilia, you should avoid the dry needling. If the patient is pregnant, you should avoid first and third trimester near the abdomen and back. You should avoid it because of the prostaglandin, it will rush the prostaglandin in, and because of that, there is a chances that patient may have a premature labor pain or pregnancy termination. Any hemorrhagic disease, we should avoid it. Old patient and sweated patients, who have profusely sweating, we should avoid it. Immediately after the hot bath, we should avoid. Just before food, it may cause vomit, and just after hungry patients, it may create the fainting. So such kind of patients should be avoided. Below 12 years of children, we should avoid the dry needle. If there is a local skin infection, it will increase the local skin infection. For example, post-herpetic neuralgia you can give, but if the herpes infection is there, you should avoid it. If the patient is on seizures, like any anti-epileptic drugs, you should avoid it because any tight contraction of the muscle may break the needle inside the muscle. Pacemaker, yes, we should avoid it because it may alter the activities of pacemaker. Any local and systemic infection should be avoided. Lymphedema, you should avoid. Patient is having allodynia, you should be avoiding this, giving the needles. Any points near the vital organs, you should be careful, like near the trapezius, patient may have a pneumothorax if it is not inserted properly, and external genital organ, of course. Now, what are the adverse effects? One is soreness and pain. So immediately after the needle, we ask the patient to give a firm compression with the help of cotton, so that patient may have less soreness and pain. Ice application is very useful. Local hemorrhage, okay, it is bound to happen if you don't avoid the large veins. So there is a local hemorrhage firm pressure for 30 seconds will give you immediate result. Sync off and giddiness is quite common. So ask the patient to not to come hungry and make the patient comfortable, then you can perform. Injury to vital organs may happen if not given correctly. Now, this is the study on the adverse effect of dry needling. You can see that even the experienced acupuncturist also causing the adverse effects. And out of that 0.7 year, 1% of the patient have a vegetative symptoms or syncope. So it is very skillful task, and you have to give the needle very carefully. Now, these are the complication of needle pain. Then patient may get nervous. Psychological counseling must. Needle dystonia, that means the needle is getting stuck inside the muscle. Needle will not come out even if you pull. So there is a thing which you can do is you can insert the another needle beneath the first one, and you can take out these two needles simultaneously to avoid this needle dystocia or dystonia. Then there is a bent needle. Needle may get bent inside, so you have to take out very carefully. Broken needle. Needle may get broken inside. Only the handle will come out. Needle is still there. So what you need to do is you have to send the patient for a surgical exploration if it is inside. There is a chance of infection and fainting. There is a chance of injury to internal organ. So hygiene measures, I would like you to read. It is very much important. Okay. Basically, there are two techniques. One is direct insertion, and one is with the help of needle guide tube. Direct insertion you can do within the degrees like 15 degree, 90 degree, 45 degree, and that we will learn practically. There is a speed, force, and depth of direction. We need to be careful about that, how you should actually perform it. And with the guide tube also you can, this is the ACTA guideline, how you perform the tiny D. There is a reason for failure if your diagnosis is not correct, if you are not managing the precipitating factors properly, if trigger points is missed, or if you have treated somewhere in the referred zone. So there is the reasons of failure. There are two types of dry needling basically. One is superficial, where the needle is going inside the skin, but it is not going in the muscle. Whereas in the deep dry needling, we are going into the muscle and we are penetrating within the trigger point. Okay, so where you can needle on the trigger points, into the trigger points. You can just over the simply painful area you can needle. Okay, and you can treat the distal proximal trigger point as per the need. This is the difference between superficial and deep dry needling, where one we are going just above the trigger point, whereas in deep dry needling we are going into the trigger point. In deep dry needling there will be a light twitch response. In superficial dry needling there will be no light twitch response. Superficial dry needling is relatively painless. Deep dry needling is, yes, it is painful when you perform. Okay, here you can see there is a no local and referred pain in superficial dry needling, whereas in deep dry needling there is a referred pain is present. Both improves the range of motion, but there is a relaxation of taut band and reduced irritability of the trigger point in deep dry needling. There is a pH normalization in deep dry needling. It is not there in superficial dry needling. So this is something. This is some difference between these 2 points. There is two methods. Patients should be monitored on functional scale, tolerance of treatment, and production of the referred pain. So these are the three parameters. And during the treatment, the patient should be monitored. There is one technique called surrounding the trigger, means around the trigger points you have to give the dry needling, and that is superficial dry needling. Now these are some of the references which you may read later on. So these are the systemic reviews available for dry needling. This is the APTA guideline, that what frequency you should give the dry needling, how you should simulate, for what minute, number of times, minutes, everything is given, and you can read it from the book. Okay, we can give the stimulation where crocodile electrodes are used. We put two needles, and these two needles are acting as the electrode. You can do it. This is the APTA guideline for dry needling. Okay, and these are the trigger points you can see. This is trapezius, this is pectoralis minor, this is rhomboid, this is deltoid, this is coracobrachialis, this is brachioradialis. Then this one is frontalis, this is gluteus maximus, medius, piriformis. This is gastrocnemius soleus, TFL, quadratus lumborum. This is the dry needling for plantar fasciitis, and this is for tennis elbow. This is sternocleidomastoid, infraspinatus, supraspinatus, levator scapula, adductor longus versus medialis, iliopsoas. These are my references. and thank you so much for tolerating me so long. I hope I have delivered the good things, and if you have any questions, you may ask. So, is there any question answer session?
Sir, we'll wait for 2 minutes for students' question here. As this
Yeah.
is live webinar, they'll ask there. We'll wait for
Okay.
2 minutes.
Yes.
Sir, students wants to know the book of your trigger point, please. That one. Dry needle book name they want properly.
Yeah, I'll be sending the soft copy.
Yes, sir.
I'll be sending the soft copy, and they may read then.
Yes, and they're also asking about the same lecture in the form of PPT or PDF if you can share with them,
Yes,
especially the
yes,
PG
I will.
students. Okay, sir.
Yes, I will share the PPT along with the book.
Okay, okay, sir. So there's many questions they have regarding the book
Okay,
entry. Yes, sir.
surely I'll send it.
Yeah, yeah. Thank you,
Okay,
sir.
thank you so much.
The useful and interesting information regarding the dry needling. Thank you so much, sir.
Thank you so much.